I love this part when people start coming in, and especially when I recognise names, like McDonald.
I know, it's great. There's always this fear that we'll actually just be sitting here chatting to each other, isn't there?
Yeah, it's fine. You know, it's all good.
That's
It's
all right
good.
too.
But yeah, welcome to our second Lisa and Pat to have a chat, or in conversation with, as we're supposed to call it. It was such a great session last time, and you know, I certainly hope it's something that we can keep building on each month, because the lovely world of compliance, there's always something new. It's like there's always something, and there's always plenty to talk about. So I'm really looking forward to the sessions, you know, that we've got coming up. And I think we've got dates booked for the up to the end of the year as well, haven't we? So,
I think we have, Lisa. I think we have, and you know, I agree with you. You know, and I think the that we, whilst we may worry that nobody turns up, I don't think we ever run or worry about running out of things to talk about.
No, absolutely. So for those of you that haven't joined us before, we are joined by the wonderful Pat Langley. Pat's whole history of dentistry, being a dentist practice owner, and now compliance queen for many years. So Pat works alongside now Dentistry Compliance, which is powered by Apolline. So great collaboration going on there. So we really wanted, you know, to make these sessions things that you guys wanted to talk about as much as the things that we feel that would be helpful to talk about. So if anyone has any questions, they want to pop their camera on, that's fine. If you don't, you can always pop it in the little, if you go down to the bottom, you can press the chat bar and do us pop us a question in there. We're happy to answer those. So I think, Pat, we were saying that it'd be quite nice to have, you know, start with audits, risk assessment. I know this is something that it's driving people a little bit crazy, especially, you know, really frustrating trying to get them done in practice and do them effectively.
Yeah, it absolutely is, Lisa. And my concern about risk assessments and audits is that that they are done just to tick a box, and that is a waste of everybody's time. So if you do an audit or indeed a risk assessment, and they are two different things. So risk assessments look at what the hazards are and the chance that harm will be caused to somebody. Risk management is how you manage those risks. An audit is really, in effect, a measure of how successful your processes are. So they are different things, and I think people often jumble them up. Now, I think my biggest concern with risk assessments and audits is that people just do them as a tick box exercise. And if you do that and you do nothing about the things that you have found, provided the audit is done honestly, and I have had lots of situations where practices have said to me, well, I found they were just ticking a box, but actually it didn't reflect reality. Then you've wasted your time completely. And not only that, the next time you do a risk assessment or an audit, it will give you exactly the same results as before. So I think that you're completely right. It's something practices struggle with. And I think they struggle with it because maybe not everybody understands why they're doing it, you know, and actually all of this stuff with risk management and risk assessment goes back to long before the CQC came along. So it's not the CQC trying to make our lives difficult. This has always been in place. So you've always had to do risk assessments under the Health and Safety at Work Act. So, you know, they are really useful things. If we turn to the CQC, though, and what they think about it, what they want is for you to be aware of the risks, to put measures in place to reduce them, and then to see whether your processes have worked by, you know, through audit. So risk assessments and audits are something that the CQC will always check on. So it is worth doing well. and it's worth doing it, just worth doing it well, and worth doing it for the right reasons, because at the end of the day, what you're trying to do is stop disasters happening and turning into what we call significant adverse incidents. So it is all good stuff to do. It's just, persuading people to do it and to make time to do it. So I think, and also, quite often it involves some kind of paper audit, which isn't, great in this day and age. I mean, at Dentistry Compliance, we have automated all our audits to make it easier for people, and you can do it on your phone and that sort of thing. I think there is a great deal of struggle going on with audits and risk assessments. Do you agree, Lisa?
Yeah, absolutely. And in particular, people not, like you say, being given the time. This isn't a job to do in between patients. This is, a regular, let's dedicate half a day or a day, once every week or a couple of weeks to actually get this done and actually plan it on an audit calendar. And I know obviously in compliance system, it will tell you when it's due and things like that, but you still do need that human input that's so important. And how we're processing those results, get into a structure, have an audit policy that tells you what you're going to do with it, when you're going to do it, who's going to do it, what we do with the actions and findings. And I think with some people it's very difficult because they feel quite like if something hasn't come out as well as they would perhaps hope, how do we tell people? How do we tell potentially our boss that his X-ray audit it's absolutely terrible, and again, this is something that you don't always get trained to do, to have these conversations. But for me, figures are figures. I'm not saying that we should, with some results, we announce them in a staff meeting and shame people. Although sometimes that works. But actually, making sure that we are, once we've got what we want, we know what we need to say, we know the improvement, how are we delivering that to the person that needs to make the improvements and changes? And that's difficult, so especially
it is so important. So and the same for patient record audits as well, not just radiographic quality, but the same for all audits that involve you communicating a message that the person on the other end of your communication is not going to welcome. So here's my suggestion for that. Let's say that you do a radiographic quality audit and it shows that actually the clinician has marked their x-rays as acceptable, and to you they are just a blurred mass of nonsense, and how are you going to communicate that? Or you do a patient record audit and you find that that the medical histories are miles out of date. Now, the way I learned how to do this really it goes back a very, very long time. But I was in practice auditing at the time a very, very well-known high-profile dentist who was, I think, chairman of something or other at the BDA. He also taught me as a student. And so, it was pretty intimidating, I have to say. And as I walked around the practice, I noticed that they had a separate x-ray room. And my experience has always been that if you have a separate x-ray room, you are less likely to take radiographs with the appropriate frequency. That's just been my finding. And so I thought, oh dear, how am I going to handle this? Here's this very high profile, well-known person who taught me as a student, and now I'm going to have to tell him that because I know I will find he hasn't taken x-rays often enough, you see. And so, because that had been my experience. And so I thought, oh, this is a bit of a challenge. Now, it was in the days when we did paper records, but you can do this with computer records as well. So he had a pile of records that he passed to me to look at. And he said, there you go, Pat, tell me what you find, see. And so I passed them back to him and I said, John, that wasn't his name, but I said, I'll tell you what, John, I'll ask you for things and you show them to me, right? So we set off on this audit, and I said, could you show me the most recent patient medical history for patient X? Yeah, of course, yeah, no problem. Scrabble through the paper records. And then he said, I remember it as if it was yesterday. And then he said, right, yeah, I remember. I didn't take a medical history for her because actually she's, she's a friend and I know her and I know she's, I know she's perfectly well. Okay, no problem, John. And then can you show me the most recent x-rays for this patient? Through. And I didn't take x-rays for her because she was pregnant at the time. Okay, no problem. Anyway, we then went on through about 4 or 5 records. And eventually he said, oh my goodness, he said, I'm not doing it, am I? I thought I was doing these things and I'm not. And I said, well, that's true. You are not alone though. And so this process of self-discovery was unbelievably powerful. In fact, so powerful, he wrote an article on it and said, I just didn't realize. So my advice in terms of communicating something that is going to be received defensively, let's call it, or possibly even badly, because if you do the record audit yourselves, then the dentist or the clinician is always going to say, oh, you just picked a bad bunch of records. And I'm sure my records are not really like that. And then you have to go, well, I think they are. And so that's really, really difficult to do. We all have to remember, and I'm speaking as a dentist here now for a moment, that actually having to criticize a dentist's clinical records is an incredibly personal and invasive thing to do. So whatever methods we can use and find to make this an easier communication process, I think are to be applauded. So that would be my suggestion. So you say to the dentist, okay, I've had a little look at your records, and there's just 1 or 2 things I'm not really very clear about. I wonder if I could just have 15 minutes of your time, and we could just go through some of the records. So show me this, show me that, show me the things you want to see, and then there's nowhere to hide. And it does sound like I'm trying to catch people out. I'm really not, because the whole purpose of this is to protect the clinicians from litigation, the GDC complaints, and all these other things. But it is incredibly effective.
I think that's that's so helpful, and that's such a great like you say, sort of confrontational way to do it. I mean, I suppose we could do something similar if you wanted to, kind of in an email. These are the stats, these are the results. Can you take a look at them? And I just need you to come back with some points of if there's any improvements to be made, and actually let them discover it themselves.
Yeah, absolutely. The trouble with that, I think you can. The trouble with that is persuading them to do it. And if you can find just a little bit of time to sit personally with them, it will be more effective. And so I really profoundly dislike doing patient record audit when the clinician isn't there, because it always triggers this defensive response. I think that if you've got a clinician who is very open to feedback, then yes, you could do it like that, and perhaps couch it in terms of these are my findings, which I thought was a little bit odd, because I know you like to keep good patient records. I wonder if you'd just mind checking these things out yourself, and then that's quite a gentle way to do it. I think most clinicians are not open to feedback given to them by somebody else about.
And I think it will come back to culture a little bit, won't it? Adopting that open, transparent. At the end of the day, we're doing this to improve systems, improve our practices, to make sure we are compliant. But that also includes protecting the clinicians.
Definitely. And sometimes they don't know they need protecting, but you're so right. You're so right.
If we can do it from a, oh, I'm so glad that I found this.
Yeah. Absolutely.
It's I'm not saying we need to sugarcoat it, because there'll be instances where we absolutely probably shouldn't sugarcoat anything. But I know that many managers here, I recognise some really experienced managers here, we know that we have to present things in a way that isn't going to get the shutters come down immediately, or
Yeah.
you get defensive. We've had a question, Pat. So what training do we require to have to complete our risk assessments? For example, IOSH.
For example, what? Sorry,
IOSH?
I don't know what
I don't know
IOSH
what that is actually.
is. Could the person that asked the question just let us know what?
Does it mean?
Lisa,
Maybe.
sorry, Lisa, it's Amanda here. It's IOSH training. It's not me that asked the question, but IOSH training is one of the risk assessment training platforms that they use.
Sorry, yes. Actually, Pat, you will know way more than me about this, but some people do like to go on to, you need to be appropriately trained, don't you? But generally in practice, we're okay.
Yes, yeah, absolutely. I think a lot of people do get very concerned about, well, how am I going to know if I'm doing the right things? And I think to simplify what a practice risk assessment is all it is a think about and probably a walk round your practice with your eyes wide open, looking for anything that could cause harm to anybody. Now, what happens when we've worked in practice for a long, long time is we go blind to that. And I remember another practice visit I was on, and there was an open bottle of bleach in the patient toilet. And I said to the practice owner, I said, "Oh, tell me about that bottle of bleach in the toilet." And he said, "I don't know what you're talking about." And I said, "Well, there's an open bottle of bleach in the toilet." Not anymore, because I've put the lid on it and removed it. And he had no idea what I was talking about. And because he couldn't see it, because he went to the loo in there a couple of times a day, and he just didn't see it anymore. So it is in terms of thinking about risk assessments, it is literally just looking at everything in the practice that could cause harm, and then looking at how you can reduce it. And you look at it from the perspective of, what do we currently do at the moment to reduce risk? And is that enough? So say, for example, you have you don't enforce a policy of all patients wearing protective glasses. I mean, I think that must be very unlikely these days, but you never know. And then, so you haven't got that control in place, or they only wear glasses for restorative procedures, and they don't wear them for things like orthodontic treatment and that sort of thing. Okay, so the risk is that, or the hazard is that you'll get eye injury. Who could be injured? The patient, possibly the nurse, and the clinician. And then what controls have you got in place? Well, I haven't got any controls in place. So what do we need to put in place? Well, we need to make sure that it is mandatory for all patients and all team members to wear protective glasses. And so, yes, you do need to know what you're doing with a risk assessment. A lot of it is common sense, though. Does that make sense?
So the risk assessments that you would recommend that we outsource, Pat, do you have a list of what you definitely think needs to be outsourced?
I don't think anything necessarily needs to be outsourced. I think that you can create your own risk assessments, or working with a compliance company and using their risk assessments. But I think, as I say, a lot of it is common sense. And if you just think about what the risks are, maybe let's think about, what are the risks of managing medicines? Well, they could end up in the wrong hands. You could give them to the wrong, you could give the wrong antibiotic to the wrong medication to the wrong patient. And so there's all the stuff around how you manage medicine. So you think about what could go wrong in managing medicines. You know, what could go wrong in assessing health and safety risks. So I think, and some practices do, of course, choose to outsource it, and I would never criticize anyone for doing that. But I don't think you have to do that. And when it talks about you need to be appropriately trained, I think experienced managers generally are appropriately trained, but don't have any formal. You don't need a formal qualification to do risk assessments and audits. Does that answer the question?
Yeah, so I know that some people, you know, obviously when we're looking at things like maybe a disability audit or a Legionella audit and things like that.
Yes, yeah, fair enough, absolutely. So Legionella, yes, absolutely. You need a Legionella risk assessment and you need a Legionella written scheme of examination, for sure. You should have a fire risk assessment done at least once by a qualified outsourced fire risk assessment person. You know, somebody who, a fire officer, somebody who is trained in fire, because you won't know whether you've considered all the potential things that could go wrong with fire. We often see in practice, though, when we go into do a compliance audit, we often see, and certainly the CQC reports this as well, we often see a fire risk assessment that has been sent back to the practice with actions on it, and none of the actions have been acted upon. Yeah. So yes, you need to do a risk assessment, and then you need to act on the findings.
Yeah, I think that's the important thing, isn't it? And yeah, I think everyone will. Again, it's looking at what the dangers might be. If you've got, you know, a one-floor practice, maybe you don't feel the disability side of things. You know, you can manage it. If you've got more of a complicated way for people, then people are coming up and downstairs and all that kind of thing, I definitely think it's worthwhile. We have an external disability audit because we do it every 3 years because we've got a very large building and we're on a main road. There's just a lot of things that we feel could potentially happen. We also do sedation and things. So and I have to admit, I think we cursed ourselves. We had a disability audit, and literally the week after, unfortunately, a patient fell over as they were entering the building. And sadly, there was no fault to us at all. There was quite a few other external things that had happened leading up to his visit. But his wife had said that the door had hit him and caused, so we had to go through quite a lot of paperwork, as you can imagine, because sadly the gentleman was taken to hospital and passed away a few weeks later. But I was so glad that we could show that we were diligent and careful. I'm not saying everyone has to have a disability audit, but I found it, especially in this instance, I was so glad.
Definitely. And was it a disabled patient then? No.
It was we have a path that leads up to the front door, and it's an automated door. He'd lost his balance and fell backwards over the bike rack that was there. But when they look at the risk and how many people come through that door, we'd also obviously had a maintenance contract on the door. We immediately called the door people out, and they plug it into, like, your car when it goes to the garage, they plug it into a computer and it'll tell them if there's been any faults or connections with anything. I was just really glad to have that, and we'll probably continue to have that probably a bit more frequent.
Yeah, absolutely. So in our system, and what you can do, because I know you use our system, Lisa, is we have an automated, we call it an access audit now, not a disability audit, disabled access. We just call it an access audit. And what you might like to consider doing is having the outsourced one every 3 years, but then doing an internal one every year. And Jodie's just asked the question, should it be done every year? And I think, yes, actually, it should. But that would be a good solution, so that you have the outsourced one done because you've got a large, complicated building, and then you do one in-house using our automated audit in the intervening 2 years.
Yeah, or if something else happens, then you would potentially, and this is the thing with risk assessments, isn't it? It's not okay, that's it, that's done. We have to, it's kind of that moving policy, that live policy, isn't it? If you don't mind, I'll just loop back a little bit to the question about the being trained. From a CQC point of view, about the extra qualifications that we might want to have or need to have if we're doing certain risk assessments. So, for example, if somebody was down as the infection control lead, health and safety lead, should we have additional qualifications or training?
Not additional qualifications. You don't need additional qualifications. I say you don't need them. You might choose to have them, but you don't need them as such. I think training, I mean, to be an infection control lead, you should really understand every aspect of infection control. So that's decontamination, everything to do with infection control, immunization, PPE, everything that infection control involves, and you should have detailed knowledge of that. But all the knowledge is out there. You could choose to attend some training on it, certainly. It isn't something the CQC expects to see a qualification for, though. In terms of health and safety, I mean, some people feel uncomfortable assessing health and safety themselves because it is such a big area, and there is training. I think the health and safety executive actually provides training in health and safety risk assessments and audits.
I think it comes down to the individual part, doesn't it, as well?
Yes,
you know,
very much so.
Appropriate training. We have in both of our decon rooms a dedicated decon person that isn't a nurse, and therefore we put them on the decon lead course.
Yeah.
I think it cost, I can't remember who it was with, I can't find out. I think it cost like £90. And it was
that's
really
very good.
It was really thorough. And actually they got they did get a qualification, and it made them feel, you know, really great as well. And they've been a massive help with audits and things.
Great.
They do go into, you know, the infection prevention massively. And also training on the usage from the manufacturers of the autoclaves and all that.
Brilliant.
Is they can be in charge of that. Everyone should have
absolutely. And that is the thing. The infection control lead should be, and deputy should be completely knowledgeable about all of that. And I think if anyone doesn't feel confident in their knowledge, then absolutely more training is imperative, I would say.
Yeah, absolutely. I know there's another comment here about, you know, I comply. You know, most systems will help you. And I know I'm probably saying this partly because Pat's here, but I would say it anyway, is I just find that the way that you look at and how your software manages the audits and risks, it doesn't overwhelm. Which for a lot of practices that I support have moved over. And that's not to say I Comply isn't great. It comes down to
absolutely. I
think the simplicity is appreciated.
Yeah, absolutely. I mean, one of my favorite sayings is that compliance should, a software system should support the day job, not be the day job. And, you know, simplicity is everything. Less is more. Keep things as simple as you possibly can, so that everybody feels they want to engage with it. I think that if it's too overwhelming, then it turns people off. It can turn people off. I remember one of our team going into a practice just after COVID, when the practice had been closed for a long time, and a lot of tasks had become overdue, and this poor person, practice manager, said she had 167 overdue tasks on the system she used, and so she just shut the computer and hid away because it was just too overwhelming and she didn't know where to start. So I think simplicity is essential.
Absolutely, yeah. No, I think that's the thing. And anybody, this isn't a sales, I promise, but if anybody does want to talk to dentistry compliance about switching over, I know that they've really looked after people and made it very, very easy switch. So don't let anything put you off having a chat and exploring whether there's a better system for you. Pat, I wanted just to touch on, because this is obviously probably going on in every one of our practices at the moment. Last time we did this, I said that I thought I was poorly. I got COVID again, 4th time. I am the COVID queen. I
couldn't believe you got it again, Lisa. I knew you weren't well.
I swear, I don't go around licking people. It's like
I know. Well, I said to you before we did the session, I said to you, you've got COVID, Lisa, and you said, oh no, I don't think so. Oh yeah, I think you have.
I know. Do you know, everybody, I mean, me and Pat have been, worked together for many, many years, and I even got like a test that afternoon and I was fine. So I carried on up the next morning. It was like I'd been hit by a bus, and then I get the messages from Pat warning me about going to bed. Don't work. It was like you were worse than my mum. Honestly,
I'm very bossy when it comes to COVID. I am very bossy.
Well, I've got to admit, it was the worst I've ever had it, and it floored me.
Oh, you poor thing.
It was
how long for?
I got up on the Wednesday morning and I was still having a little cry on the Monday the following week.
Oh, Lisa, that's horrible.
I know. And yeah, you know what, as managers, we've got so much to do. I think it was that I was crying about as much as anything.
Yeah, no, I understand that. Well, I had my brush with COVID in July. Don't know where that came from. And like you, I thought this isn't COVID, but we were having a long organized family party. And one of my cousins has got terminal cancer, and absolute battle axe of a woman, but is sort of, it's kind of a case of, well, I'm not going to let cancer get in the way of what I'm doing. But I thought, incredible woman. But I thought, no, I cannot put people at risk. So I had this absolute banging headache. I don't know if you got that, because all the symptoms are different for different people. I had a banging headache, runny nose, cough, and so on. And so I thought, well, I'll do a test, you see. And I had an old test kit as well. And I thought, well, it probably won't work anyway. And then within about, I don't know, 2 or 3 minutes the line appeared. And I just, honestly, I couldn't believe it. I thought, well, I don't know where I've been to catch anything. But I did. And so I think that it is doing the rounds again. And it appears to me that whilst the variants don't become more lethal, they do seem to become more infectious. So I think, going back to some of the things you did in COVID, I think is really important. So I think screening patients before they come in, and actually, even if it isn't COVID, it could be flu, it could be respiratory syncytial virus, which is nasty. There are a pile of other horrible viruses around as well. Some diarrhea and vomiting viruses around too. And so it is really unwise to treat patients or allow team members to work if they are unwell. Now, so I think that, and so if you have a patient who either has tested positive for COVID or has symptoms, and as I say, they do vary between people, but the things to look out for are horrific headache, that shattered as well, absolutely exhausted, like you said, as well, and exhausted, cough, all those sorts of things that are the traditional COVID symptoms, then I would suggest to dental practice team members, do a test. I know it's not a requirement, but it's I think it's the right thing to do personally, and don't go to work until it is negative again. How long did it take? And I know that's a difficult ask because not everybody will pay sick leave for that. How long before your test went negative, Lisa?
It was I did it on I was doing a visit to another practice on the Tuesday or Wednesday, so I did it just to be certain. But yeah, I did it on the Monday and then I did it on the Tuesday, and Monday was still there, the Tuesday had gone. So it was just over five days. I think, you know, weirdly, I was like, only a couple of people in work knew. I'm like, for goodness sake, don't tell the team, because I don't need everyone. You know, we've all got people who sometimes like these, you know, these situations. And the number of practices though that really have problem with staff not wanting to take the time off because they may not be paid. I know that is a real problem for a lot of managers to try and manage. And it's the same with, you know, like you said, gastroenteritis. I think there's been a release today, I need to look at it, of some epidemic that's going around of that and what we should be doing. But for me, you know, one of my dentists, Monday morning, you know, 7 o'clock, gastroenteritis. Okay, she can't come in for 48 hours from the last time that she vomited. And we've just cancelled tomorrow as well. That's a dentist, that's a bit different, but I think we need to make sure our contracts are clear and that we're fair and we help people, you know, if they are genuinely worried about losing money, because we're making them go off for 48 hours. I think we just need to try and get through this winter as healthy as we can.
I agree. I do agree, Lisa. I do. I think it's really, really difficult, and I think that you know, not all practices will think that they are able to pay people through a sickness period. If you can, I think my advice would always be to try and do that. But if a practice finds they can't do that, then I think if somebody is as ill as you were and I was, you can't go to work because you're flattened, and that's just not something you can do. But I think if your symptoms are more mild, then if it's your team that isn't a dentist, then removing people from clinical duties onto non-clinical duties, and perhaps not isolating, but moving them to a part of the practice where there is less likelihood of contact. Maybe ask them to wear a mask. And I think, you know, after my brush with COVID, although, you know, too late because the horse had already bolted, I did wear a mask on the tube in London a few times, and I have noticed a few, you know, that's happening a little bit more now. But I think also it's very easy to forget some of the rules that we put in place during COVID, you know, washing your hands frequently, and you know, making sure it's thorough hand washing, and you know, coughs and sneezes caught in a tissue and straight into a bin. But I think, I think an awareness of the problem, that the problem is not going, it's never going to go away. So, you know, and I was amazed that I got it in summer. You know, how does that happen? But,
weird one.
It did. So, and I think, you know, everybody will have had protocols that they used during COVID. Just have another look at those and just see what you can do that is, you know, within reasonable, that it's reasonable to achieve. So, for example, my husband still brings his scrubs home every day and launders them separately, which he didn't do. He didn't do that before COVID, but you know, it became a habit that stuck, and I think it's a, you know, it's a good habit. So just revisit some of the things that you did during COVID and just ask, you know, are there some things that we should bring back in now?
I think some practices, I found it helpful, you know, many of us do courtesy or confirmation calls, you know, and giving a little bit more time, you know, it might be that you do it more than 24 hours before. I know it's never going to be a foolproof, complete solution, but having a really good cancellation list so that people can be brought forward, you know, from a business point of view, we need to try to be able to function. And actually practices that can absorb the odd person off poorly. I think it's important that everybody knows that we've all got to pull together. Practices, smaller practices that have to either cancel a clinic or get a locum in, I just completely sympathise that that's obviously.
I do too, you know, and I think it's in that situation, it's back to astronaut dressing, really. You know, sort of take every single precaution you can not to pass it to your patients. And, you know, if you have a vulnerable patient, you know, somebody on immunotherapy, or, you know, the list of patients who are vulnerable that we used during COVID, then postpone their appointment.
Yeah, I had one comment that I got when I had COVID, and this started even a couple of weeks ago, was oh, well, COVID doesn't even exist really anymore. And I think there will be some patient challenges. I know that we've all had our share during the COVID epidemic, but we will be faced with, if we're cancelling patients because the dentist has COVID, or we can't allow you to come in because you've said that you've got a cough, and, you know, etc. Patients feel that, you know, because other people are going to work and carrying on as normal, that healthcare should be the same, and it is like completely different.
No.
I mean, we all know that. There's lots of, you know, the AGPs.
Absolutely. And also you're at very, very close proximity. You know, there isn't really much else, opticians maybe, there isn't really much else that you get right up close and personal with your patients. And so, you know, if you, as a dentist treating patient or a dental nurse leaning over the patient, vulnerable patient, and you've got COVID, I think there's a high chance that that the patient will get it. So
one of my clinicians actually a few weeks ago had whooping cough.
Oh, nasty.
Yeah,
nasty,
I know, and I've never, you know, I always thought it was a very old-fashioned thing.
But no, it's not. Yeah, well, it was, but it reared its ugly head again recently in quite a big way.
Well, yeah, I mean, it was a very intensive course of antibiotics, but the whoop is real.
Did they?
Honestly,
Yeah.
So these things are definitely creeping around, and I think it's important that we make sure that our team are all on the same page, you know, particularly reception, when we're having these discussions with patients.
I think that's incredibly important, but I think it's also extremely important that the practice owner takes into account how everybody in the practice feels about it. So if the practice owner makes a decision about this is what we're going to do, we're either not going to wear FFP2s or 3s, then make sure everybody in the practice is happy with that, because you know, I can just imagine a less than confident dental nurse, and the practice owner says, well, I'm not ordering any more FFP2 or 3 masks. You know, we'll just have to get on with it. And you know, it would take quite a confident person to speak out against that. So I would always say to practice owners and to dentists, just make sure that whatever decisions you make, everyone is comfortable with it.
Yeah, absolutely. We are coming up to our quarter 2. We've done very again. I'm just always conscious that we like to give you time to grab some lunch if you've not already had it. Has anybody got any incidents that they'd like to share, that or concerns that have cropped up that's a bit unusual on the compliance front over the last few weeks? Anybody have any real worries about maybe upcoming inspections if they were to happen, or anything like that, people can contact us directly. I know
Definitely,
so
definitely
helpful and always on the end of an email for us when there's a
Always.
question. Yeah, no, and just having somebody that's able to respond to us really quickly.
Yeah,
You know that the compliance team is growing, isn't it? So you guys
yeah, no, it is very much so. And you know, customer service is our middle name, and you know, I think being there when needed is just so important. And you will always get a quick response from us in terms of anything that is a concern to you. And I don't know if there are any people who use our system on here, but if there are, and you've had an issue, then I hope that's been your finding, because that is very much what we believe is very important. And you know, sometimes people just want to say, well, you know, did I do the right thing? Again, always there to answer questions like that.
I think that's the nice thing, you know, the nice thing about this partnership with the Practice Managers Association, because it really is.
Oh, right. Have you seen what Michelle has written? Signed up after the last session and done it yourself for 30 years.
Oh, Michelle treated herself. You're so worth it, Michelle.
Welcome. Please
really
yeah, please do reach out to me personally, and if you would like to with anything. So my hats off to you. Done it yourself for 30 years. That's a big job to do.
Change. It's going to change. Honestly, Michelle, you'll feel so much part of the community, and you know, don't be afraid to ever feel back. Feedback rather. I spoke to Ryan. Many of you might spoke to Ryan if you have ever spoken to the guys at Dentistry Compliance. And Ryan has now dipped his toe into the practice management world and compliance world, and I saw him at the Dentistry show in London at the weekend, and he said, oh my goodness, I cannot believe what practice managers have to do.
I know.
I really want to help them. And I said, you're doing a really good job, because I've gone back to him a few times and said, do you know, it'd be great if it could do this, it'd be great if it could do that. And I've said to him, you're basically like my fairy godmother. I'm going to make a wish. So nobody be afraid to go to Ryan and go.
Indeed, and that's how we've developed our systems, from client feedback. I had a call yesterday with a very senior person at a corporate who we've worked with for years and years, and she said, are you interested if we have a significant incident? I said, yes, we certainly are. And there'd been some kind of mistake made, that I won't go into the details of. And I said, you know, if you have something really significant go wrong in your practice, do please tell us. We can advise you if you need advice, but also we can look at our systems and see, you know, are we doing absolutely everything we can to try and help that ever happening again? Yeah, always there to help. And that's the whole, that's what, you know, when I was a dentist doing clinical dentistry, my driver was to make a difference to patients. Now it's to make a difference to practices and teams, because I do know just how monumentally different it all is.
Yeah, no, and I do think that personal touch does still, you know, does come through massively, and I know I appreciate it. So yeah, we start. Yes. So if anybody has any topics you'd like us to cover next month, I think the next one is, please let us know, because you know, this is for you guys. You know, me and Pat can talk forever, as you know.
Can and have done.
But you know, come to us with questions. You know, we want you to feel comfortable, because whatever's going on with you is probably going on with the rest of us as well, or will do. So it is good to share. But thank you, Pat. As ever,
pleasure.
Absolutely fantastic. Thank you, everyone that's taken the time to join us. Thank you to Sam from Adam, who has set us up, got us going. Probably gone to get a brew while we're all talking dentistry.
No, I'm listening. I'm eagerly listening. Very interesting, even though I don't work in a dental practice.
Poor Sam, poor Sam. She's quite happy with her 10 cats at
And cats, yeah.
home. Thank you, everyone, and get in
Thank you very
touch if
much.
there's anything in the meantime.
Absolutely. All
Thanks,
right.
guys.
And thank
Thank
you, Lisa.
you.
Thank you, Sam. Thank
Thank
you,
you.
audience.
Thank you, Pat.
very much.
Bye-bye.
Bye-bye.
Thanks, everyone. Bye.